This is a talk on effectively how you go about doing a SERAP. I'm not going to sort of inundate you with literature. You're more than capable, probably better than I, to read that up in the databases and the manuscripts and bits and pieces. But we'll take it on and effectively take you through what a SERAP is, how you go about planning and performing one, perhaps most importantly, some tips and tricks. And they don't always go beautifully smoothly, don't get me wrong, and it's not a cure for everything below the renal arteries and the aorta and the iliac. And Harj and Martin are going to take you through some cases, some interactive cases, and sort of throw questions backwards and forwards. And there's no wrong or right answer to these. We've sort of learned as we've gone along with experience, but we've made lots of mistakes, and hopefully some of that we will prevent you from making when you start up as a consultant in your own right. So what is a SERAP? Effectively, it's an EVAR of the aorto-iliac bifurcation for sternoclusive disease. At its very simplest, it consists of an aortic stent into which you chimney two iliac stents, one from each common iliac artery, to create a bifurcated graft, an internal bifurcated graft. I think that definition is probably a little bit too simplistic. Certainly in our experience now, we are treating anything below the renals right the way down to the femorals, included in terms of an internal graft. And thus, from our perspective, a SERAP effectively is a combination of techniques to treat aorto-iliac sternoclusive diseases, more often than not with an element of a hybrid procedure in terms of femoral endarterectomy or complex femoral reconstructive surgery. The diagram on the right sort of shows you the very basics of it, and that's a diagram pinched from Peter Goved, who as a person and as a unit along with Michael Reikkonen, certainly had the largest experience of this, having coined the term SERAP. I think other people have done SERAPs before they termed it SERAP, but like everything, once you put a name to it, it's sort of associated with yourself. You've probably seen Peter talk at quite a few of the conferences in relation to his experience. And like I said, I'm not going to hit you with literature, but this is the largest case series from that group, dating back to whatever it was, 2015, of 100 SERAPs. And yeah, they get good primary and secondary patency rates. Whether or not that's a suitable outcome is still open for debate, obviously. But perhaps most importantly, the complications are quite low when you compare it to open surgery. And if we take sort of systematic reviews or reviews of open surgery, this is what I did 10 years ago. But to be fair, most of the large series in this area are from the sort of 90s and the early 2000s. And yeah, you do get perhaps a bit better patency rates in terms of from an aorta bifem or ilio-fem or endarterectomy. But as with everything, as you know, these can be quite complex procedures with multiple complex steps of refashioning the aorta, refashioning the femoral, and along with any complex open surgery comes heightened risks of morbidity and mortality, as demonstrated by the incidence of perioperative morbidity and mortality here. So an EVAR, or not an EVAR, a SERAP, if you like, is an internal aorta bifem in most aspects. So if we look at how we go about planning these, so what invariably happens is, certainly in our unit, there's a couple of us who do them. So it tends to be myself and Mr. Rate who does them, or Mr. McMahon who's got his in-laws over, hence why he hasn't joined. And more recently, Mr. Saratzis has joined us, who's taken on the role as well. And we effectively get referred patients from either within the hospital, from other areas of the region or outside the region even. And when we started off, or when I started off doing these, I started off being quite conservative. Pick your winners is what I was told by my more senior colleagues, and that's sound advice for anybody starting off as a consultant, particularly if you're planning on introducing a new technique. But we've got more aggressive over the last couple of years, and like I say, we will take anything on from the renal arteries down to the femoral in terms of stenting, whether or not it be occlusive disease or sternoclusive disease. So you want to take a rough estimate as to whether or not you think this is a feasible procedure. And in this case, he's got aorto-iliac disease. Is the distal third perhaps of his aorta is occluded, and it's extending down to his bifurcations of the common iliac arteries on both sides. Femoral arteries look okay. So I think this is a feasible one to do when you're starting out, provided you've got the skill set to get you through those occlusions. If you've got the skill set to get you through the occlusions, then you can perform a SERAP. What I would say, though, is you need to know your bailout strategies before you start off. Once you've ascertained whether or not you think you can do it, then start to look slightly more closer. Where does the disease in the aorta start, stop? Is the visceral vessels involved? Is the IMA patent? Do you need to keep the IMA in circuit? You're not trying to form a seal here, so you don't have to worry about seals according to EVAR principles. So you can chimney into the IMA with relative impunity. Particularly those patients who've undergone sort of left-sided colonic surgery and who marginal artery adjustment might have been disrupted. Iliacs, extent of calcification. Circumferential calcification can actually be a blessing because you can sort of bounce your wire off on it inside the lumen. The so-called calcific bergs or calcibergs, where you just got dense calcification throughout the whole vessel, can be a real challenge, even to the most technically experienced endovascular surgeon or interventional radiologist. And then you've got to look at your access. Like I say, the vast majority of the ones that we've done, we include a femoral end arterectomy and some form of external iliac treatment. Certainly in our experience, the potential drawback to CERAB is not so much the aorto-iliac stents, it's the external iliac arteries themselves. And the ones who've ended up having sort of repeated interventions tend to have repeated interventions for external iliac artery disease recurrence. And once you've done that, then you plan it. So you've ascertained that it's feasible, and then you go about planning it on whichever 3D software that you have. And you plan it exactly the same as you plan an EVAR. It's just that rather than being a big artery this time, it's a blocked artery or stenosed artery. You create a map, and depending what you like, I like to hand draw them. A couple of my colleagues like to have technical detailed drawings from a computer. But you come up with a map which effectively details the lengths and the level of diameter above and below the blockages or narrowing. It's nice to get on the angulation for those if you're planning on keeping the internal in circuit. I'd certainly advise you to keep the internal in circuit if you possibly can. We've sort of progressed, I guess, over the last sort of 3 to 4 months to formalizing this. And Cesar, who's one of our senior lower limb fellows, has come up with this diagram, which I think is very useful, actually, particularly when you're starting out, because it reminds you of what you should be looking at, very much like an EVAR diagram. Most people who experience an EVAR don't, use the cook planning sheet. They will use their own sort of planning in their head, etc. But if you're starting out in something, it's good to have a crib sheet, and you're more than welcome to a copy of this. I'm sure Cesar will be quite happy to send it out to people. Sorry, go ahead.
Matt Popperwell's trying to get in. Can someone let him in, please?
Yeah.
Sorry to interrupt.
That should be the morning. There's a whole gaggle of them. Right, okay. Okay, they're in, good. So effectively, you've got to decide which stents you want to use, and I would strongly recommend using covered stents. Okay, the Europeans, or certainly some of our European colleagues, like to use uncovered stents. They are, to be fair, cheaper, but I strongly recommend using covered stents. And I'll show you a case at the end of this, which sort of illustrates that quite well. And these are the stents that we use. There's nothing clever about them. Most of you have come across all of these stents, particularly if you're involved or your unit does FEVARs or BVARs. The B-graft aortic stent was originally designed for sort of coarctation disease. It works well. It's not as nice as the V12s or the VBXs, but it does go up to a much larger size for your aorta. It's chrome and cobalt as well, as opposed to stainless steel. In your iliacs, I tend to like to use the V12 or the old atrium stent, as they were previously termed. My view is that once I find a stent that works, unless somebody comes along with a version which is as good and cheaper, I won't change, or unless somebody comes along with something which is better. And to be fair, the Gore VBX, which has come out quite recently, is a good stent. It does have benefits, which we're going to shortly, but it is quite substantially more expensive. And more recently, the B-graft has come out, Plus, which is a greater radial force than the other two, supposedly. Once again, my experience with the B-graft is limited to a couple of cases, and I went back to using the V12. External iliac artery, people debate this until you're blue in the teeth, if you like. Effectively, I like to use the wire bands because I tend to deliberately rupture the external iliac arteries to see if I can improve the flow. If you're not planning on doing that, Cook Silver or another comparable stent graft, or some of the more modern ones, if you like, can be used as well. So that's purely a personal preference. I don't work for Gore, and I certainly don't work for Bentley. So you need a good working knowledge of these stents, really. And like I say, pick a couple and learn them well. And the reality of all of these stents is they come in these funny sizes, and the difference between a 19mm stent and a 20mm stent is negligible. So just remember them as 20, 30, 40, 50, and 60. And most of the others come in at a similar sort of size. The B. Bentley stent grafts, or the B grafts, are actually effectively only 3 different stents, irrespective of what the diameter says, according to which sheath size they go through. So the 12mm diameter B graft is a separate stent. The 14 and the 16 are identical stents, just different inflation pressures. 18, 20, and 22, to be fair, the 24 is a different stent, but the 18 and 20 and 22 are identical ones. The sheath size is always a little bit awkward because the sheaths that I use don't come in as a 9 and 11, so I'm having put them through a 10 and 12. You can obviously get 14s, but depending what sheaths you've got on the shelf or which companies you use, you can get 9 and 11s. What I have found with the B grafts, it is a small company, to be fair. It is a German company. They do make relatively decent things, but they're not as good as the Atriums in terms of how well the stent is applied to the balloon. And they come with a sort of a yellow plastic sheath, which you insert into your sheath port before passing the graft through. And we've had a couple of the stents move up and down the delivery system as a result. And one trick we found to get around this, it's not particularly clever, but you just inflate the balloon ever so slightly before you pass them into the sheath, and it just gives them a little bit better approximation. They do dilate up to different sizes. They will dilate up to the next stent size. And so if you remember, the 12 is separate to the 14 and the 16. So the 12 will get up to 14 and indeed a 16. However, the different stents will shorten when they dilate. And if you remember your maths, your pi r squared times length, a 12 by 39, the volume of a 12 by 39 is the same as the volume of a 14 by 29. So if you blow a 12 uniformly up to a 14, it will shorten. Now, the caveat to this is there is a degree of stretchability in these stents, particularly in the ones with EPTFE. So they don't shorten predictably, and it's difficult to predict whether or not they're going to shorten equally, distally, and proximally, or just shorten in the middle. So blowing them up uniformly across the whole stent to a different size stent is not a wise idea. Flaring them doesn't seem to shorten them significantly, but you need a short, larger balloon to do so, at least engaging it in a slightly less way than the full length of the balloon. Common iliac artery stent grafts, well, like I say, there's 3 main ones. There are other ones out there. There's Livestream. I got no experience of that, but I suspect it works very much similar to these 3. Once again, they come in these sort of slightly odd sizes, which you soon get used to. The ones we use the most of are either 8mm or 9mm diameter ones, and typically a 58 or a 59 and a 38, or some variant of those 2. Like I said, the B graft plus, it's a slightly odd graft. It's a double layer of chromium cobalt, which allows its radial force, and then it's sandwiched between 2 layers of EPTFE. So they're saying utilize it for calcified lesions. To be fair, I haven't had any trouble with the Atriums or the V12s for calcified lesions either, nor the VBXs. The V12s, like I say, are pretty good. The one thing I like about these is that they all can pass through a 7 French sheath, no matter what the size is. Now, you might say, why does that matter? Well, it means that you don't have to do a pre-close if you're utilizing a ProGlide system. Now, you can use an angioseal, but most of these patients, if you are deciding to do it percutaneously, will have an element of disease in their femoral artery. And angioseals don't do particularly well with calcified femoral vessels, or you're more likely to run into trouble, certainly in my experience. So the V12 are quite nice like that. They have the smaller sheath size across the spectrum of the diameters. Gore VBX, it does come in a slightly longer length, and the other has a 79mm length compared to the others, which are maximum sort of just under 60. It is a good stent graft. Gore tend to do good stents in my experience, and they do tend to say what they do on the tin, or do what they say on the tin, I should say. They are expensive, these. They're about 50% more expensive than the V12s. So the benefit that you get from utilizing one stent in the common iliac artery, if it is of the right length, can be offset. They do dilate up quite nicely, and the one thing that they do have over their other competitors is they do have the length to, so if you dilate an 8mm up to a 10mm, they will tell you what it was shortened by in terms of length, so there is that sort of caveat as well. But you won't go too far wrong if you use any of these 3, to be perfectly honest. I just have a preference for V12 because that's what we started out using. So if you think about what you're doing, you're effectively putting 2 smaller stents into 1 big stent. And the misnomer here is that we had this from another center when they asked us to look at a case for them. is they will take the view that you can fit 2 half-diameter stent sizes into that one big stent. So in 10 millimeter, you can put 2 5 millimeters. Well, it doesn't quite work like that. You can actually put a substantially larger stent in terms of doubling them up into a larger stent. So if you remember your pi r squared, so you're looking at the surface area. So the rule of thumb is if you have one large stent, you can fit 2 stents into it, which is 70% of its original diameter, and create a seal. So what that means is with a 12 millimeter aortic stent, you can seal it with 2 8 millimeter, round about that, common iliac artery stents to create a truly sealed bifurcated graft. Likewise with a 14 to 10 millimeter stents. The other thing is it works sort of a progressive quadratic equation. So 3 stents, you can put 3 60% of the original sizes in, which becomes quite important when you're figuring out whether or not you can chimney into the aortic stent or if there's enough space to chimney into the aortic stent. So it looks a bit pedantic, but it is quite useful, particularly when you're creating sort of double Ds into the original large aortic stent. So you get your plan and then you figure out what you want to do. So this is a relatively straightforward sternoclusive disease of the aorto-iliac segment extending down to the common iliac artery bifurcations. There's no right or wrong answer to this. So you can put a 14 millimeter aortic stent in if you want. I would probably put a 12 millimeter stent in and just flare the top end to 14 millimeters and then seal it with either 2.8 or 2.9 B12s at the bottom. The IMA is occluded, you don't have to worry about the IMA. I wouldn't get worried about the internal on the left, obviously, because it's occluded. So you want to go from a map to having an idea of what stents you're actually going to put in. And furthermore, what stents you might need if you're going to measure lengths and things intraoperatively as well. So you need a good consignment of stents, or at least order more stents than you require.
Rob, sorry, Nikesh is trying to join and you're the host. I can't let him in.
Sorry. You in, Nikesh?
You okay? What about that?
And please, can people mute your microphone?
That's better. You in, Nikesh?
I'm here.
Okay, cool. I'll keep going. So if we just look at, I'm not going to take you through step by step in these example cases because Harj and Martin are going to do that. So what I'm going to try and do is just give you some examples of what looks feasible and what doesn't look feasible and perhaps ways in which I would approach it. So in this case, you've got somebody who's got aorto-iliac disease. It looks quite calcified. Looking at that, I think that's perfectly feasible for doing a CERAB without too much difficulty. If you look at the MIP here on the left, you can see it is quite calcified. In fact, the occlusion on the left common iliac is quite calcified in itself. And you create a map, we use TerraRecon, as I said earlier, and you come up with something like this. And effectively, they've got aorto-iliac sternoclusive disease, where the common iliac artery occlusion on the left is not just the common iliac artery, it's sort of mushrooming up into the aorta. And the one area that I would say is very useful to know is that's the magic number. When your aorta is at 12 millimeters, I wouldn't go stenting it. When it's below 12 millimeters, I would start thinking about stenting it if you're doing CERAPs, okay? You can get away with kissing stents and things, and Martin will take you through some of that. They've got very good results from kissing stents, but purely from a anatomical perspective, if you're doing a CERAP in terms of how I'm describing here, 12 millimeters is your magical number. The other thing here is you've got an IMA, okay? You've got a bit of disease above that. I wouldn't bother with that disease whatsoever, okay? And you come up with your plan, which is a straightforward 2 iliac stents and an aortic stent. And that should be relatively straightforward. And then you think about how you're going to do it. And my advice to you is when you start out doing these, take your time to plan it and have it exactly in your mind how you think you're going to do it. And this one doesn't appear to be any common femoral artery disease or external iliac artery disease, so it's plausible to do as a percutaneous procedure. Make sure you know how to use your angioseals and proglides very well, because the last thing you want is after a long procedure, because they are quite long, these, is to run into trouble with the angioseal or the proglide. And you must have sheaths which are long enough. You don't want to be inserting, particularly through occluded arteries, the B Bentley bareback, because it will come off. And the atriums are a lot better at staying onto the balloon, but I wouldn't insert those through anything which is quite tightly narrowed either, bareback. So you want sheaths which will go from your groin up into the aorta above the disease. And we use Cook Ansel, you can use whichever ones you like, they all do pretty much the same, but know the lengths. A 45 or 55 centimeter one takes you from most people's groins up into the aorta without any difficulty, and doesn't mean that you have to think about how much stent you got in or how long the shafts are. So you start off, and let's say you've punctured both groins and you've got your, I don't know, standard 4 or 5 French sheath in the groin, and you decide to do runs up those simultaneously, and you end up with something like this. And the reason why you're not seeing anything in the aorta is that the flow down the internal on the right is taking it all down the internal, and you're not getting anything up the aorta in a retrograde fashion. So the problem here is you haven't really got anything to aim at, particularly for the occluded side. So if you're lucky, you get your 5 French or 4 French measuring pig up into the aorta, and you do a run from up there, from the right side this is. Ignore the wires, it's just purely for illustrative purposes. What you end up getting is a very nice aortogram, but nothing going further down the way. And the reason for that is that your 4 or 5 French sheath has effectively plugged the stenosis segment, the critically stenosis segment in that common iliac artery, to the extent that very little contrast is going down there, and it's all shooting off down the collaterals. So once again, you haven't got a full roadmap for yourself to use. So what you want to be doing, let's get rid of this pen thing, is you want to be able to do a run, typically a pump run from your aorta, as well as firing from your sheaths down in the groins. And there's a couple of ways of doing this, and it depends on what you're comfortable doing. So I like to come down from above, from the brachial approach if I can, because I don't have to worry about, you know, what you do at the end of the case and how to do the runs and everything, because you've got the sort of backup wire at the top. Alternatively, in this one where you've got a stenosis, if you like, in the common iliac artery, you're fairly confident that you're going to get through that without too much difficulty, although you can dissect up the edges of these stenoses unless you're careful. But if you can get a pigtail catheter or equivalent into the aorta, you can upsize your sheath. So you can go from a 5 French system to a 7 French system and inject around your pigtail catheter in the groin whilst you do the run from above. And once again, you can get that sort of above and below pictures to give you a roadmap from which you base everything else. So once again, it comes down to what you're happy doing. Those which are completely occluded, I would always come down from above. I think that's vital. I wouldn't go dissecting through bilateral occlusions which involve the aorta without having some idea where the aorta becomes relatively normal. Otherwise, you get yourself into trouble. So once you've got your angiogram, start figuring out how you're going to get through it. And I'll just try to illustrate this. So if I get the pen. So on this one, I've got a pigtail catheter through, and effectively what I've started to do, I've started to poke retrogradely. And the issue here, and I'll show it to you slightly better in the next slide, is that you can find yourself, it looks logically that you keep poking, it's just going to come in there. And what tends to happen is it comes here, it doesn't like that because it's got a calcified cap on it, and it disappears up here. And the next thing you know, you're dissecting up the aorta until you hit the IMA. And for some reason, it always hits the IMA. Okay, and then you can lose the IMA or worse. So I must admit, I prefer to come antegrade through occluded iliac segments, which are extending into the aorta. And one way of doing it, you come up the contralateral side and just go down like that. Okay, and there's some caveats here in that you might find your wire buckles up like this. Okay? In which case you can put a stiffer sheath or a sheath which has got an angle on it, and even those can buckle, to be fair. And if you're struggling, come down from above, because you get a long, stiff sheath down here. Okay, and you can quite easily get, you know, a 9 or even a 10 French, depending whether or not you're going for auxiliary or brake, or even subclavian, you get something slightly larger than that, and you get a lot more purchase. But not only that, your angle of attack is you're leaving just that disease segment there. So you're not breaking out here and back in, you're leaving in that disease segment there. Okay. Now, some people say that you can come up through here and then use your outback to get back in. And yeah, that's a perfectly valid technique. Your outback's about 1,100 pounds though. And your V Bentleys are already 1,000 pounds, and your V12 is 700 quid each. And you're planning on using perhaps 4 of those and 2 Bentleys. And quickly either your commissioners or your boss or your manager say, this is a very expensive endeavor, go back to doing aorta by fence. So whilst perhaps it's counterproductive, have a way of keeping your costs down as much as you can. So if we look at what I was trying to explain with the breaking out and breaking back in, so this is sort of an extreme example. So you've got a bilateral occluded iliac extending into your aorta. And what you've done, you've been lucky, you've got through here. Okay, so you've got retrogradely up through the left iliac and you've broken out of the tip of the disease. Okay, the disease never looks like a glass of water at the top. But on the other side, what you've done is you've come up subintimally and you haven't broken back through there, you've broken back into the aorta where there is no disease, much higher than what you think. And unless you're careful, you cannot notice that or pick up on it. And you go from that to deploying your bent knees, say you deploy them up on the left this time, you deploy your bent knee into the lumen of the aorta there, and you've actually covered where you've broken back in. So when you pull this wire back thinking you're in the aorta, just alongside of that bent knee to recannulate up there, you're in a different plane. And you can get yourself into trouble doing that. Okay. The worst case scenario is that you load your bent knee onto that side, the wire which is broken up much higher, and you actually deploy it in the subintimal plane because you think you're above the occlusion on your roadmap there. So you've deployed it there from what you think, but you're actually in the subintimal plane. And what that does, it tents the media and adventitia here, and it can tear it. And suddenly you've got your normal aorta, relatively normal aorta above it, going out through there. And they don't do so well when that happens. And then the only thing you can do there is, in terms of bailing out without opening them up, is actually getting a balloon across there whilst you ever think about it, and then deploying another B bent knee there within the lumen. And then suddenly you've got a competing B bent knee there within where you want to be, and a B bent knee there where you don't want to be, which will then compress your CERAB configuration here because of Laplace's law. The larger the stent, the greater the tension it would be for the same pressure. And these will be crushed by that bent knee. So you get yourself out of trouble by putting your B bent knee across there, but you basically negate your ability to do the CERAB. So you're then having to push yourself into doing an aorta bifurcation, which you've made more complex because you're closer to the renal arteries. So once you've got your B bent knee stent up, okay, or you've crossed the lesion, I should say, then you've got to decide where you're going to put your B bent knee stent up. So let's say you put it up and it goes there, okay, and you put up the left, right? So what you've got there, you've got your wire through, you've got your contralateral wires now being pushed up against the aortic wall, okay? It's not outside the aorta, it's against the aortic wall, and it's got to be pulled back, and you've got to cannulate your B bent knee graft there in order to get both your V12s within that B bent knee. So it's exactly the same as cannulating a contralateral limb within an EVA. Now, that's one way of doing it. Let me just see. Let me just clear that. The other way of doing it is you put your B bent knee there and you've put it up through your left side. So your left wire is through it, allowing you to put your V12 without any difficulty down that side. This side, your left side where your occlusion's all blocked here. Your left side where the wire's gone up is there. You've now got to pull that back into your bent knee. And you run the risk, if you do it on the side which has got the occlusion, of pulling your wire back into the occlusion. And what you find is at the tip of all these occlusions, they've got this sort of calcified plaque which you sort of rammed your wire through. There's no delicacy to getting through these things. You've literally rammed your wire through. And if you pull it back behind that calcified plaque, you can lose that hole quite easily and suddenly you have to redo it again. So these patients who've got an occluded side compared to a stenosed side, it seems a little bit counterintuitive. Put the B bent knee up the side which is occluded, because then you're less likely to not be able to get back into your B bent knee when you pull your wire back to cannulate it. Once you've got both wires through the B bent knee, then it becomes very simple. You just deploy both your V12 stents or the equivalent. You can use measuring pigtail catheters just to make sure you've got your lengths right. Increasingly, we do that and sort of ignore the lengths on the map because 9 times out of 10, we change the configuration halfway through the operation just by saving a stent. Sometimes we put a VBX in if it's 79 millimeters or it's treated with 79 millimeters just to keep the cost down because 1 VBX is cheaper than two V12s. But that's sort of neither here nor there in terms of the actual technicality of the things. But be careful in losing the purchase of your wire going back up your B bent knee. Here's another sort of case that illustrates a couple of points. This is a patient who has a complete occlusion of the aorto-iliac segment. as demonstrated here. So the map, if you like, looks like this on the left, okay? And here what you're seeing is that the disease is extending up to the IMA. So if you remember your 12 millimeters being your sort of, your Goldilocks number, 12's probably coming in there. And you've got disease above the IMA. Now, some people say this is an overkill. Other people advise you to keep as much of the arteries as you can. So for myself, I mean, to be fair, this chap didn't have an SMA disease. Let's say they had SMA disease and they'd had a left anterior resection or something. So their marginal artery adjustment isn't intact and you want to keep your IMA there. There's a number of configurations you can do this in. You can either do it as a sort of a tripartite sort of chimney snorkel system like that, where you put your B Bentley above and then bring your stents down into these. Or you can do this, which is sort of a petticoat design where you're building it up two at a time. So you've got your B Bentley above here. You put your snorkel in for your chimney in for your IMA here, and then you put another B Bentley in there. And you build up your V12s into that B Bentley, but below the IMA, because there's a little bit of space there now. Now that's how we originally did these IMA chimneys. But what we found is that B Bentley once again competes for that IMA stent, and we've had ones which have crushed the IMA stent. And once again, I guess from a physics perspective, it might be down to Laplace law. It just might be down to our incompetence. But we've moved on to that configuration. We've had better luck with doing these. And don't get me wrong, we haven't done loads of these. We've done about 8 or 9 IMA chimneys overall, I think. So that's our sort of standard IMA chimney configuration as it currently stands. I'm sure it'll change over the next 10 or 15 as well as we learn a bit more as we go along. Once again, you don't have to seal here. So it's not like for EVARs. You don't have to worry about getting a seal, because sometimes you actually want to keep as many of these sort of lumbar collaterals going as you want. The only time where you want to guarantee a seal, as good as guarantee a seal, is if you're deliberately planning on rupturing everything. And that tends to occur for patients who've got very calcified disease. You're having to go to high pressure, subsequent balloon inflations to get your stents to fully open. And you can see them pinging as they rupture the common iliacs or even the external iliacs as you do so. And for those, you do want to obviously have a good seal. So in this case, you've got the aorto-iliac bifurcation, which is occluded going up into the aorta. That's the run. You come down from above and you've got your sheaths and your groin. You've done simultaneous run. Increasingly, you don't need to use huge amounts of contrast to do this. I use 8 mils a second. Some people even use even less because there's nowhere for the contrast to go here apart from out the collaterals, so it hangs around for quite a long time. And you go through your standard steps. And once again, just don't rush it. Always do this with a colleague who also knows what they're doing, or even another colleague who also knows what they're doing, because effectively you've got wires going up from the groin, you've got wires coming down from the top. Most of these you've got your registrar who's also trying to learn to do them as well. And you just physically can't think of everything that's going on here, keeping an eye on what's going at the top and the bottom, as well as trying to train somebody at the same time. So the more people you've got who can actually give you a hand and keep an eye on things, the better in my experience. So once again, you've got your wires through, you deploy your B Bentley, okay? And then you cannulate that from the contralateral limb, so you've got your 2 stiff wires going up. And then that's the stage where you can actually relax because you've done the most difficult bit. You've got through the occlusion and you've deployed your B Bentley and you've got your wires through it. The worst comes to worst, your IMA, you can't get into the IMA at the bottom of the B Bentley stent. Tough. You just put your V12s in and forget about it, okay? So you're almost gilding the lily, if you like, with the IMA stent. If you can do it, fantastic. If you can't, don't worry about it. But you've now got access and you can just build up your V12 down the common iliacs, down the external iliacs as you wish. Okay? And effectively, you end up with a configuration that looks something like this. So this is a follow-up CT scan about a year after the original. And the IMA stent is still flowing. So when I started putting the IMA stents in, a couple of my more senior colleagues said, oh, you're just wasting your time, they're blocked. And they don't block, they seem to do quite well. For patients who got not just aorto and common iliac disease, but also have external iliac and common femoral artery disease, okay, endarterectomize them. Don't be tempted to just do everything percutaneous, accepting less than perfect femoral arteries or external iliac arteries. Like I said earlier, the one area where we've run into trouble here, or not so much into trouble where they've gone back for further procedures, is because we haven't suitably been aggressive on the external iliac. And for those of you, who do lots of sort of open surgery, you can endarterectomize up to there by underneath the inguinal ligament when you do a femoral endarterectomy, and that does one of two things. If you're coming down from above, you don't have to worry about breaking back in anymore, because if you keep pushing to where your endarterectomy segment is, you will find yourself straight back into the lumen, because you've removed a third of the media and the intima. So the actual technical challenge of breaking back in an antegrade fashion has gone if you endarterectomize your external iliac artery. Circumferential vessel calcification, if this was all calcification, okay, it actually helps you wire find the right way, and actually gives you a bit more purchase of, butting into the disease from the bottom and coming out from the disease at the top. So you come down here, and once you hit the calcified disease, provided you've got a bit of luck and a trailing wind, you find yourself bouncing back into the lumen. Calcified occlusions, on the other hand, are not easy, particularly when you've got these big chunks of almost like teeth in the artery blocking it. And this is one we did, well, quite recently actually, one of Mr. McMahon's. And what you can see here is somebody who's got dense calcified disease, and they've got a complete occlusion of the left common iliac artery in addition to everything else, with this sort of Kausberg's, very calcified vessels. And we did exactly what we did normally. We tried to come up and go down. We came up and went down like that originally, and just couldn't get any purchase to get into this calcified lesion, because once again, it was mushrooming into the aorta. So we came from below, perforated the vessel, okay? Don't get worried about that, it's an occluded vessel, okay? So all you have to do is pull your wire back. What I would suggest you do if you do that, because you get the contrast doesn't dissipate, is you suck it all out before you do it, and perhaps flush it with a bit of saline and then suck back again to get rid of it. So this is a picture after, and you can see all the contrast is actually gone, okay? Pull your wire back and just start trying to get into a different plane and going up somewhere in that direction, if you like. And eventually we got through, and it was a struggle. We spent a good hour and a half getting through all this disease. And we get our B Bentleys up, and you can see us building up our stents here, and then building up our stents further down. And you can start seeing what I'm trying to illustrate. That's your vessel there. That's our stent there. And it's nicely illustrated here. There's the stent. There's the vessel. So we've recanalized it all subintimally, and then we've blown up the vessel, which has effectively torn out the side of the adventitia for all intents and purposes. And it didn't bleed, it didn't have any trouble intraoperatively. He had a bit of a hematoma in his good groin, interestingly, which is why we've got the repeat CT scan about 2 weeks after. And you can see the stent outside the artery, confirmed on the sort of the sagittals and the cross-sectional ones. There's the stent, there's the artery, there's the wall of the artery, the aorta, and here's the stent. Stent, iliac. So, great tip, okay, use covered stents. So if we hadn't used a covered stent in that procedure, then we'd have had a huge bleed, and we'd probably gotten ourselves into trouble. So I can't reiterate enough, use covered stents as much as you possibly can. Like I say, there's a vogue at the moment in Europe because the uncovered stents are cheaper to use uncovered stents. I would accept the increased cost and use covered stents. Other tips and tricks we've learned, listen to what the patient tells you. A lot of these patients just don't come in with a calcified, occluded aorto-iliac segment. They've often had a claudication for long periods of time and suddenly got worse over the last year, typically 2 or 3 months or something. And invariably what happens, they've got underlying chronic atherosclerotic disease, and then they clot off the residual stuff until the, we call it, collaterals come in. And all this stuff here is just mature thrombus. Now, with mature thrombus, you can get a lot of mature thrombus out with a Fogarty catheter with a wire kept in it. You can get through it, and you can clear as much as you like. Yeah, you still have to stent and everything, but you converted it from an occlusive disease to a stenotic disease. Okay, so those patients who've got disease with a history which suggests it might be acute on chronic and have got that pattern disease from top to tail, if you like, on the left side, I would open up the groin and see if you can Fogarty it out. If you can't Fogarty it out, at least you can endarterectomize that segment there, making your antegrade recanalization much easier because you don't have to worry about breaking back in. Let me just clear that so I can illustrate the next point. Similar with coda balloon buddying, if you like. So for this one, you could bring your wire up here and go down there. And like I said, what happens, it comes up and it buckles. And all that you end up doing is pushing wire further and further up. And people who've got really calcified vessels there, even with a supporting catheter and a supporting sheath and, you know, something within something within something, you can still get everything buckling up. So what you can do is you have to upsize your sheath size a bit, to be fair, but you can pass a coda balloon or something equivalent and blow it up there, okay? And when you pass your wire up, it bounces off the coda balloon so that the direction of force suddenly becomes in the direction that you're passing. And you get a bit more purchase, and we've had a couple of occasions where that's just been good enough to allow us to get through from an anti-grade fashion. So it doesn't always work, don't get me wrong, and you'd have used that sort of technique for other things, but for ones where you're struggling to get anti-grade, where you haven't come down from above, okay, and you don't want to come down from above, perhaps they've got aortic arch disease or your left subclavian's occluded or whatever, having a couple of tricks up your sleeve just to try first before you then bite the bullet and come down from above can be useful. Know your bailout strategies, okay? And this is what happens if you blow up your Bentley, in the wrong place, etc. And this comes down to just thinking about what can go wrong and hoping that it doesn't, but having all the stents available to make sure, there's the silly things, dropping the V12 or something and only having ordered one of them. You need a good consignment, and you need to have ordered all the stents that you require. What I still try not to do is that those patients who would be suitable for an open surgical procedure, I try not to do a CERAB, which would make that more complicated. As in, that tends to pertain to, I don't go buddying or stenting down the renal arteries to take your B Bentley above those to treat disease up there, okay? Because that means that your subsequent aorta bifem, if you are going to do that, involves a suprarenal clamp. So for those who are deemed suitable, so as in somebody you're having a discussion with CERAB versus an open operation, I would still try to maintain as much as possible your CERAB below your renal arteries to the extent that you can clamp below the renal arteries and not through the stent. If you've decided they're not suitable for an aorta bifem, then you can start to push the boat a little bit more. But once again, chimneying lots of things and bits and pieces does take it to the next complexity. And we do occasionally, push the boundaries, if you like. Just a couple of cases as we come to closes to demonstrate that. It's not sort of blowing our own whistle, because quite a few of them have complications that we didn't expect. This is somebody who's got a very calcified aorto-iliac disease, who's then got an aneurysm, small aneurysm on top. Okay, that was their MAC. They came in with critical limb ischemia. They weren't suitable for anything. They were significant comorbidities. That was their angiogram. Okay, and you just think slightly outside the page. You look at that, and I thought, well, I can put a B Bentley in there, but given their history, I suspect quite a lot of this is relatively fresh thrombus, and the worry here is that it colgates down into the renals, and she'd already got renal artery renal dysfunction. I didn't particularly want to go putting wires to put balloons down those either to spare them. So once again, you come back to that surface area thing, 2 8mm stents, you're not looking for a seal. They will more than stand up in that because they're being held throughout the whole of that length of that sort of calcified aneurysm. And we just built it up with V12s at the very top, and then wire bands through the rest of it, and then with high pressure balloons, and she's done very well. Similar here, this is a chap who came from our HPP colleagues, had a laparoscopic cholecystectomy, which unfortunately went wrong. He came to us about 6 weeks later with this picture from his aorta, which we thought was either a trocar injury or an infected aorta. They swore blind that they hadn't got a trocar injury, and to be fair, it was a very experienced surgeon, so we put it down as a mycotic aneurysm. He wasn't the sort of person that you wanted to go undertaking intervention in terms of open surgery for this for. So to begin with, we'd done this before in another chat previously. We put an Amplatz plug it actually into the pseudoaneurysm and then covered it with a B Bentley. And then what we found, so you can see the Amplatz in there, this is the follow-up CT about 2 weeks after, is that they developed another mycotic aneurysm further down. And although you can't see it on this, there was all sorts of little patchy stuff going down to just the aortic bifurcation. And we thought, oh Christ, okay, we made a balls of this. But once again, he wasn't very fit. So we made it up into a CERAP, taking all the way down to the common iliac, so taking it as far as we possibly could before starting to sacrifice other vessels. And this is him 2 years later. He's been on antibiotics. He's on antibiotics for 6 months. He's come off them now. 2 years later, he has his aorta, if you look, I mean, to be fair, you can't see it in the 3D reconstruction, his aorta, if you look at it, almost looks plumb normal. So whether or not it was a trocar injury or a truly infected mycotic aneurysm is open for debate. I thought it was almost certainly mycotic given the way it sort of spread down the aorta, but we seem to have got away with it. So some of you who sat the exam in Leicester might recognize the case. So in summary, SERABs, you can do what you like with them, to be perfectly honest, provided you've got the skill set and confidence of being able to get yourself out of trouble. I would find yourself a buddy or somebody who's equally adept at recognizing when something's going awry and getting you out of trouble as well. You do rely on each other, or three people even. Start simple and build yourself up to something more complex. And whichever unit you're in, there'll be somebody who's adept at getting through iliac occlusions. It doesn't make a difference if they're vascular surgeons, interventional radiologists, or even the cardiologists. Okay, find somebody who's interested in doing it and helping out and developing a service along these lines.